Hi, my name is John Marshall, and welcome back to my video blog, which Medscape is silly enough to post on its website. Our job today is going to be really to tackle one of the most confusing bits of data that we've received lately in the world of colon cancer. Briefly, we know that the VEGF antibody, bevacizumab, worked in frontline metastatic disease. It worked in second-line metastatic disease. We've seen there's some data that suggests that you should continue the bevacizumab up until progression, and even some data that suggests that maybe even beyond progression bevacizumab works. Likewise, the EGFR antibodies, cetuximab, for example, has shown benefit in the frontline metastatic setting, in the second-line metastatic setting, and of course most prominently in the third-line metastatic setting. So these antibodies, when given separately, have benefit throughout the line of continuum of care in metastatic colon cancer. And of course, both are being tried in the adjuvant setting. And then comes along this study known as BOND-2. This study was really a very small study, about 80 patients done in the United States. They were all refractory colon cancer patients. Half of them got just the two antibodies, bevacizumab and cetuximab. The other half got bevacizumab, cetuximab, and irinotecan. And fascinating though it was, and small though it was, the patients who got the three drugs had a 38% response rate in a refractory colon cancer setting. That was miraculous. It was an incredible signal that said something was going on between the EGFR and the VEGF antibodies. And of course was the foundation, those 40 patients were the foundation for testing these antibodies in 3 large randomized trials in the frontline metastatic setting. I like to think of them as the 3 ships set sail, the Nina, the Pinta, and the Santa Maria. Unfortunately, 2 of the 3 ships have already crashed, and 1 remains on the open seas. But let's briefly look at those 3 studies. The first, known as the PACCE clinical trial, looked at dual antibody therapy. FOLFOX bevacizumab was essentially the base, although you could also give FOLFIRI bevacizumab. And then half the patients also got panitumumab. And of course, we all know the results of this trial because it was negative. The dual antibody arms of this clinical trial were too spicy. They were too toxic, and in fact, the outcomes were worse. The criticism of we as investigators in this trial was that we hadn't thought ahead. We hadn't done adequate phase 1 and phase 2 data collection before launching a big phase 3 study. And frankly, we sort of hung our head and said, maybe you were right. But then came along the second of these studies, and that was presented this year at ASCO, and it's known as CAIRO2. Now, it's a Zelox-based regimen, so Zelox Avastin plus minus cetuximab. Here, we had safety data that said that the dual antibody arm, Zelox plus cetuximab plus bevacizumab, was not overly toxic. It was an acceptable toxicity profile. On the other hand, we saw the results from ASCO this year, which suggested that the dual antibody arm was actually inferior. It was worse than the single bevacizumab only arm. Even when one controlled for KRAS, there was not an improvement, and in fact in the KRAS mutants, if you gave dual antibody therapy, the outcome was significantly worse. So here now we have 2 large randomized trials, both of which suggesting that dual antibody therapy is in fact negative. Well, the third ship that's still out there is of course the CALGB cooperative group trial, which takes either FOLFOX or FOLFIRI and randomizes patients between cetuximab, bevacizumab, or both. And yes, they've modified the trial to account now for KRAS, but they kept that third arm in, the arm with the dual antibody therapy, to try once and for all to answer the question whether frontline dual antibody therapy is a good idea or a bad idea. Well, I think what we have to do is be very careful right now, because yes, you've got 2 randomized trials suggesting negative outcomes with dual antibody therapy, but that BOND-2 signal is extremely strong. In fact, I often will, in a refractory patient, deploy that BOND-2 strategy of bringing the 2 antibodies together, and I promise you it's clinically active in some patients. So what happens between a frontline patient and a last-line patient that makes all of a sudden a BOND-2 or dual antibody strategy effective when in fact it wasn't in frontline therapy? I think that's going to be our challenge for the future. So my punchline takeaway is don't sort of say that all dual antibody therapy is evil. Clearly, frontline metastatic colon, outside of a clinical trial, it is not advised. But we still need to mine this last line signal that we're getting from dual antibody therapy in a refractory patient. Thanks for joining me.